For instance, even in the US, in more remote areas, there's a bigger use of telehealth.
That is Afua Branoah Banful, a McKinsey alum with a PhD in economics from Harvard. Afua, who goes by BB, runs Sound Health Advisory, a consulting firm that works with healthcare organizations on adoption of transformational healthcare information technology. She also advises the vendors of health IT. In this episode, we discuss the world of telehealth, how Alexa and other home voice devices are getting involved in healthcare delivery, and operational improvement opportunities at hospitals. BB also tells me about why she plays piano every morning and how she got into painting by watching YouTube videos. To learn more about BB, visit her LinkedIn profile, and the link is in the show notes. I hope you'll consider signing up for the weekly Unleashed email. I will send you the transcript of every episode, book recommendations, and consulting tips. You can visit umbrex.com and click on the Unleashed tab. Hello, BB. Welcome to the show.
Thank you so much, Will. I'm so excited to be chatting with you.
So, BB, I can call up, business colleagues all over the world and do a Zoom video conference, and a lot of times that can eliminate the need to have an in-person meeting. But it's not so easy for me to just get on a Zoom video conference with a doctor and, get diagnosed or have a prescription. I know that you have done a lot of work in telehealth. What's going on in telehealth? What's going on right now? And what should we expect to see over the coming months and years?
Well, I should say, right now is a really exciting time in telehealth because this year the CMS has changed regulation that industry, this would be the healthcare providers and both health IT vendors, have been asking for a while. And that is to reduce the number of restrictions on ability to actually use telehealth with patients. And in some cases, ability to get reimbursement officially from the CMS. So some of you who would have been following telehealth for a while would know that there have been many years for which we said telehealth is about to explode. But I think right now with some of these CMS changes, it really is about to happen.
Okay, and just for me, for my benefit, what do you mean when you say telehealth? What's the definition?
So you would hear some folks call it telemedicine, telehealth. I just use it the same term. Broadly, telehealth is the use of communications, electronic communications, let's say, to enable healthcare remotely. So you can think of big buckets of applications for telehealth, as in one would be when it's a professional to another professional. Think of a primary care specialist contacting a cardiologist or another specialist to get more information and guidance on what to do with a patient. Another category, and the one that some of the listeners may have been familiar with, is when you as a consumer can directly call up your provider, or the provider calls you up, and you have some sort of direct connection between you, the patient, and the provider. Let's call that the direct-to-consumer visits. And then there's a third category, which is the use of a device. So remote monitoring, using some device to collect data and send it for interpretation, or just in live track what is happening with the patient and act on it if something happens.
Oh, awesome. Okay, I hadn't thought about all those three categories. Yeah. What is the status today? So let's say in the United States, are there medical providers, are there doctors where you can go online and do a video conference and get a prescription? Is that like legal at all, or is it more?
Yeah.
Yeah.
Most definitely. This is where the industry has been going for a while, trying to get these direct-to-consumer visits more and more part and parcel of how healthcare is delivered in the States. So today, either through your insurance company or through your employer in some cases, or the health system, there are various ways in which you can connect with a provider, especially for urgent care. Because one of the advantages that health systems and various providers have found for using telehealth is that it's often cheaper or a lower cost site of care, as you say, to see patients for those lower acuity conditions like colds or unknown rashes or some coughs. So you can do that today. It is legal. It is nowhere near happening as often as was predicted, but it is happening.
And I've never done that. Like, are there companies that have sort of doctors on staff there, or how does it? I have healthcare insurance. Like, how would I even go find a provider to do I have how would I even find a provider to who would do that? Is it like companies, or do I find like an individual doctor? And how does that work?
So let's talk about, again, three models. One is when there is a telehealth company, a vendor that has the IT and also decides to bring on a physician group practice of some sort to provide services using that IT. So you may have heard of companies like American Well, Teladoc, MD Live. You can go online right now, download the app, and have a consultation with them. And they do everything from lactation consultation to psychotherapy to urgent care visits, right? You can do that as a consumer. And there's a second category where a health system would have bought a technology, and the health system's own providers use that technology to have visits with known patients, or in some cases, first-time patients. So let's say you have diabetes and you have to go and check in with your provider every 3 or 4 months. One time they can say, hey, for our next check-in, if everything's going well, we can do this by a video visit. And then you can talk to your own doctor or nurse practitioner using that visit. And then there's a third category where there are institutions, well-known institutions like in healthcare, CVS, I'm not sure, I think, yes, Walmart is actually doing that, Walgreens for sure. They have, as you know, minute clinics, all these sites of care in some of their locations. Now they're expanding that where you can actually also see a provider using telehealth without having to walk into the minute clinic, right? They're sort of even slashing down the time further for you to access care as a consumer using their services.
Oh, that's pretty cool. So that Minute Clinic is great. I got a flu shot there the other day, and
right.
It's easier than going to the doctor's office.
They can't quite do the flu shot over telehealth yet.
I got that. Okay, so there's some companies that do this, and then how does how does it work with the reimbursement? So like with the companies that you mentioned, like American Well or MD Life. Do they take insurance, or is it only sort of cash pay with those kind of companies?
The short answer is yes, they do take insurance. There have been caveats which have made the adoption slower paced than many would have wanted. And this is why the new rule changes by the CMS this year have been exciting to both the vendors and the healthcare providers. So in the past, if you wanted to have a telehealth visit, for simplicity of actually executing whatever programs that had been set up, most of these places would say, just give us it's something like $49.99 or $49 a visit, and we'll see you. And if you have insurance, we will go through the process and help you get reimbursement for that. Now, health care providers themselves are beginning to adopt and implement telehealth solutions as part of their service delivery. So it's becoming more typical as or compared to when you walk into a doctor's office, give your card once, and they know you, and then you can have some services there every now and then. They'll ask you, check your eligibility again. So you can do it both with direct pay from your own resources, or through your insurance with some amount of copay, often minimal.
And then how does it work kind of, legally for the healthcare provider? I imagine that some things you can sort of just diagnose by asking a bunch of questions, but, some things, historically, I would think, I'm not a, doctor or anything, but, they take your blood pressure and they look at your vital signs and stuff. So if they can't sort of evaluate you in person, what sort of limitations does that put on the kinds of things a doctor could prescribe or do?
I think it's useful to think about the sorts of use cases for telehealth and actually look at which conditions require a touch-based solution and which one you can do over the phone or with video. I was particularly shocked to learn that the biggest cost drivers in the EDs, emergency departments, or ERs, as some people call them, were conditions that were actually very low acuity. And most of those kinds of conditions, or something like 60%, could be effectively treated with a virtual or telehealth interaction. Now, even if when you think of more acute conditions, such as wound care or psychiatric visits, for instance, there's a whole host of conditions that you can do without having to touch the patients. Think of the last time that you walked into the either mini clinic or wherever that you did go. In some cases, taking your blood pressure or taking your weight was just a formality, but the meat of what they had to do, they could potentially have done with speaking or observing you. And this is why video visits really enhances the number of conditions or the range of conditions that you can use telehealth for. Right? And to add to that, there is a whole host of peripherals that have been created now that consumers can have with them at home, that in some cases automatically send the information that the provider needs, so that they can have a richer telehealth interaction.
That's really cool. So that gives us a little sense of, it sounds like things are changing in the U.S. Tell me a little bit about like the rest of the world. Is the U.S. behind some places? Are there some places that maybe where doctors are very remote, where this is even more established? They're ahead of us.
Mm-hmm. I would say that you hit the nail on the head when you talked about remote. It's not so much U.S. versus the rest of the world. Where necessity has driven, there has been more use of telehealth. So, for instance, even in the U.S., in more remote areas, and I don't mean remote, I say more sparsely populated areas, there's a bigger use of telehealth. And it's more recent that we are understanding the value to even having telehealth in places like New York, Boston, DC, right? So talking about what use cases there have been in the rest of the world, I understand in the military, for instance, Veterans Administration, they have had a keen interest on using telehealth for several years, especially for battle situations and when it's specialist treatment would be hard to access. So I wouldn't quite say US is behind. It is more of how we are using it and the extent to which we're using it.
Cool. Tell me a little bit about some of the kind of the barriers to adoption and some things that are going on to address those challenges.
Right. There have been significant headwinds in the past. And I'd say one of them, when health care providers have looked at whether to do this or not, has just been not really understanding the regulation and the reimbursement, right? So this ties back to right now, CMS will allow the provision of telehealth in MSA that is not considered rural. In the past, there were certain MSAs in which you could use telehealth and others that you couldn't. And even when it was allowed, it had to be in specific origination sites. For instance, you had to go to one provider's site of care to be able to connect with another provider. In my opinion, that sort of defeats part of the purpose of the convenience that you get.
Right.
But that was exactly what they were concerned about, where that there would be so much overuse because it was so convenient. I think there isn't hard evidence to say that that is not an issue, but the value of having telehealth more broadly in making sure people do have the interactions that they needed is being more and more appreciated. So that concern is at times put at the back burner. So some of the headwinds, I'd say, has been regulation. The other has just been users being both the patients and the providers not really knowing what it was, and just thinking, well, if you have a condition that you really want attention to, you better go in and sit in that waiting room with all the other sick people, right? And I'd say that the third has been the lack of the right incentives. Because if you are asking providers and consumers to change their behavior in some way, there better be incentives in place. And it shouldn't go against their self-interest. So with reimbursement not being clear, in the past, you could have been asking a provider to replace an in-person visit that they knew they would get, let's say, $150 for, with a telehealth visit that you would then say they would only get $50 for.
Doesn't seem like a very, very good trade. I would leave my video conference off if I was a doctor in that case. Okay, cool. Tell me a little bit about your work in this space. So, I understand that, that you, in our past discussions, that you serve health providers and sort of adoption of healthcare information technology. Tell me a little bit about kind of the types of projects that you do.
Right. So my introduction to telehealth came when I was in the corporate strategy group at a company called Advisory Board Company. And I was asked the big question of what should we do in consumer? And with my team, this was about 5 years ago, we looked around and I said, this thing, telehealth here, is going to become more and more important, especially as value-based care incentives come to the forefront. So the work that I did was primarily around understanding the vendor capability at the time, and it has changed dramatically over the past 5 years. And then looking at what the early adopters in the health systems were doing and some of the challenges that they were facing. So I would say, sadly, the challenges that they were facing 4 or 5 years ago are still very much in play today. And they would be in a couple of, you would see these patterns over and over again. The why the adoption that they were trying would either fail miserably, or in some cases just be meh and wonder why they should keep going on. And I'd say the biggest issue that I saw was not being able to disambiguate the big strategy they have into tactical goals. So there would be a splash around, we want to use telehealth to improve our patient experience or to improve patient access. But they weren't able to turn that into specific goals, like which population segment are we going to go after? Who are the kind of providers are going to use it? What's the use case? What's the technology that we need, right? And another category of typical issues that observed would be when the health system had even decided on the use case, sometimes they weren't able to operationalize it because often they did not acknowledge the effort and the resources it took to operationalize. So you would have a team of CXOs, the CMO, CMIO, like Chief Medical Officer, Chief Medical Information Officer, maybe Chief Quality Officer, who have like very hefty day jobs, being tasked with also delivering on operationalizing whatever the strategy was. And that never worked well because it took so long, they lost steam, and it never really materialized beyond like little pilots, right? And let's see what else. I'd say another area of challenge has been even after they're able to implement some pilot or have one or two use cases, it sort of falters because they're not able to scale the adoption. Right. So there would be pilots that had a lot of enthusiasm in the beginning, but one champion would leave and the whole thing would fall apart, mostly because they're not able to market what they're doing effectively so that consumers want to take it up, providers want to use it, and that they're able to show that they've had impact.
Now, so you, it sounds like you came into the whole space of healthcare and consulting in healthcare, actually, through that work at the advisory board. You did a PhD, right, in economics, right. And I think you did work on like fertilizer use in Nigeria, right?
Yes.
Could you tell us a little bit about that, and maybe if there's any things that that you learned in your doctorate now that you applied to the work in medicine?
Right. So let me actually correct you there. My work in healthcare started when I was at McKinsey.
Okay, great.
So the whole story is, to me, it makes so much sense, but someone has told me, like, I don't see how you ended up here, but I'm very glad that you did. I grew up wanting to be an engineer and wanting to go to MIT. And when I was at MIT, I discovered the power of the social sciences. And so took up a second degree in economics and then decided to do that in my graduate work and focus on international development. Hence, you see the work in fertilizer and food policy and such. But after doing that for 2 years, I wanted to have, let's say, more rapid impact and at a bigger scale. And I thought private sector could do that. So went over to McKinsey and was focusing on doing public sector, social sector work at McKinsey. And through sheer happenstance, because staffing and timing was right, I did an ED throughput, emergency department throughput study, and was hooked, fell in love. I had found my mission-driven passion, as it were, in healthcare. So I started doing healthcare work, mainly hospital frontline operations, hospital operational efficiency, that sort of work at McKinsey. And then that's when I left to go to advisory board, which is healthcare focused, to focus on it.
What are some of the things about hospital operations that that you've seen, that you've worked on, that you've seen improved, that us as patients walking in, we're sort of behind the scenes, but what are some of the operational improvement opportunities that exist at hospitals?
Mm-hmm. I would say the biggest change, which maybe you as a consumer can begin to see, is all deriving from value-based care incentives. Now, to explain that a little bit, you may understand that in the past, hospitals were paid on what they did, fee for service, volume. So it had really nothing to do with the outcome that the patient saw. It's just what was done to them. So this is why you as a consumer could go and have had an x-ray a month ago and go to another site of care and they say, we need the same x-ray again. We're going to take it again, not because we think anything has changed, but because we can, and we will get paid for it. Right. And this is simplifying a little bit the incentives and some of the reasons why that was done. But it was a very duplicative and wasteful process. And the incentives were not in place for that not to happen. Now, with the changes in reimbursement approach, where more and more hospitals are being asked to pay for outcomes, hospitals are being asked to produce outcomes and are paid for the outcomes, you're seeing changes in operations where there's more focus on data sharing, where providers are talking to each other more about the patient, trying to make sure that there's less duplication. And that has positive impact, not just in the cost of care of healthcare, both to the patient who would have some out-of-pocket contribution, but it also has impact on the patient experience and the quality of the care that they are receiving. So I've been in healthcare now for going on 8 years, and even in that time, both as a patient and when you go into hospitals, just the sort of discourse that you hear, there's more focus on being more efficient in whatever it is that they're doing, because now the incentives are pushing you to be.
Well, it's good to hear that change is happening. So rather than just getting paid to do more and more tests on us.
And can I tell you, Will, I used this example with my mom the other day, and about fee-for-service versus value-based care. And she seemed to track, so I just want to share it. I told her it was like going into a restaurant, looking at the menu, and just seeing the meals with no prices whatsoever. And then the other catch was that the amount that you paid would be different than the amount that the person sitting by you paid, because it depended on what the chef who made your food decided to do versus what the chef who made the other guy's food. For every step, they could decide to charge, and the amounts that they charged could change without explanation, and definitely wasn't transparent to you. So it just was mind-boggling to her that system had existed for so long. And I am sure that there are reasons why this is the way we were paying, and actually indeed are still paying for a lot of our healthcare service based on the activities that are done instead of the outcomes. But it's something that I personally am so excited to see is changing, because it just seems to make sense.
I love it. Love the analogy. And they could, serve me and charge me for 2 or 3 bowls of soup.
Yeah, they could drop one on you, and it doesn't matter. Yeah.
And not whether I like it or not. That's cool. So now that you kind of being in the healthcare space, been doing it for 8 years. Tell me a little bit about the range of work. So I understand that you work with providers on kind of adopting healthcare IT. Can you give us an example of a project that you've done? You sanitize the details if necessary.
Can I expand just what I do also, just so I make sure I don't forget to talk on it? I also work with the health IT vendors.
Okay.
So it's not just with the providers, right? So with the providers, it's mainly about helping them evaluate what the options, right? Helping them pick from hopefully what a good set of options is. So one project would be looking at an opportunity to use telehealth and saying which use case would make the most sense. And primarily the option was using it in urgent care, which you could make a big splash about, or in a more quiet and less flashy, frankly, use case of doing pre and post-op visit follow-ups. So over there it was helping them think through what the strategic impact of using that as a first use case for telehealth would be for the organization is, and what the economics were. So what I found is that when it comes to adopting new technology in the early stages, there's going to be a lot of forgiveness if there's no ROI. But very soon and invariably at some point, some CFO or even the director is going to have to justify why the expense is being made. And if you are not using it for a particular segment of the population which could ever hope to return any ROI, it becomes a question at that point why you started. Right? So helping them pick the use case for which they're using the solution.
Mm-hmm. And what about kind of implementation and, kind of actually getting adoption and so forth?
Right. So on the implementation side, it's mainly about helping them just design the workflows. It is a very, actually, sadly, common, but also big indicator of telehealth program about to fail, when the thought is that you will just put the technology in and keep using the same process, or basically you're going to make the process that was in place electronic. So you have to be thoughtful about the operational changes that you need. And in some cases, the changes in the people infrastructure. You may need a role that wasn't in place before so that you are not wasting the time of the physician who is now online with somebody checking their insurance eligibility. Whereas in the past, it may have been fine to send the patient straight in because you had the information on file. If you're doing things in a virtual visit, you would need to have an interim step. That may not have been there in the full touched patient being present on site situation. So some cases they don't think about things like that and put the technology in and then find that there's a big pushback and backlash from the physicians, nurse practitioners who are finding themselves doing work that nobody thought would arise out of using the technology.
Tell me a little bit about your work with healthcare IT vendors.
It's also around evaluating new opportunities, but it is more directly related to the go-to-market strategy, right? So helping them think about the product that they are working on. Is it a worthy problem that they're trying to solve? Is the solution that they are putting out there promising? Will someone pay for the solution? The thing with health IT today is that the hype is just laid on thick. If you throw in AI, big data, and what's the third one there, like analytics, you get people looking up. Much of that in practice is not what is needed to actually move the lever on the problem that's being solved. So helping them separate out what sounds like is going to get you good early investment, angels and seeds, to something that is actually going to have a believable path to being a sustainable business. Because health systems and payers, who are usually the paying entities for these sort of solutions, they require quite a high bar of proof and a high bar that it's worth it taking their money, and not just the money, but even the time it takes to implement, because you are asking providers who are already inundated and very busy to do something different and change their practice. So just helping the IT vendors put themselves in the shoes of the people that they're going to serve and make sure that the solutions are actually practically what are needed.
What are some of the healthcare technologies that you're most excited about that are kind of, that are sort of on the early part of the adoption curve?
I think very, very early is voice-enabled solutions in telehealth. And I'm sorry, pardon me, in healthcare. And my mind threw in that word telehealth because it really is telehealth when you're using a voice-enabled solution. So I worked with a company that is thinking through how it can use AI like Alexa or Google Home to help with managing chronic conditions, both when the patient is at home and on the provider side, right? That was really exciting because when you think about the population that is driving the highest use in healthcare and the population that suffers most really from a high burden of managing their conditions, they're often 65 and above, multiple chronic conditions, may have some impairment or disability. And I have found voice so freeing in my own experience in use. And I'm excited about the possibility that we can bring solutions like that to healthcare. So you can ask, instead of asking a patient, record your blood pressure every day, record your weight every day, you can give them a solution where even if they take the blood pressure with a non-Bluetooth enabled cuff, they can speak out the answer instead of having to find a pen and paper and write it down and keep track on it. You can even go a step further by just giving them the Bluetooth enabled cuff. They just do it, it's recorded, and then they can speak with Alexa or Google and ask, what trend am I on? What changes do I need to do today? So yeah, that's something that I find exciting.
Or I imagine your home device, Alexa, can say, "Hey, Will, it's time to take your blood pressure. Put put the arm thing on."
Yeah. Will, get up and take a walk. How about that?
Or take your pills. Boy, I'm really going to enjoy that. Like, Will, stop eating that. You said that you were going to stop. Well, couldn't you find some vegetables? Oh my God. So Alexa's going to be telling me what, to remind me to take the pills or to get some exercise. Or just, hey, time to take your blood pressure. So I can easily imagine that, because even being sort of, fit and relatively healthy, it's like sometimes hard if you're trying to take, you have some prescription or something for a cold or something. It's like, take this 4 times a day, 3 times a day. You like totally forget at lunchtime. And, for someone who's older who has the whole kind of pills throughout the day, it can, it's like a major job.
Yeah. Yeah. And people are taking 16 different regimens. Some of them have to be tailored depending on the weather, depending on what they've eaten. It's just really exciting to be able to have that support without, it's almost like you have the physician or the caregiver in the home with them, because you can program the solution to take into consideration what has been happening and spit out the best answer for the time. It's an improvement on asking people to remember. So I'm really excited about that.
That's very cool. I'm curious about your own personal productivity routines. So you are accomplishing an amazing amount. And what are some sort of habits or practices or daily routines that you found really helpful?
So I should call out that many people will, I think, identify with this. I got into independent consulting because I wanted to be productive and yet have a life that I was happy with in terms of balance. So in productivity, I'd say I mix a good dose of living activities with work activities and consider them almost part and parcel of what I need to achieve each day. So I play the piano. I start my day each day by playing the piano for at least 30 minutes. And I have recently taken up painting. So I try to fit some painting in maybe 2 times a week. I'm laughing because I wasn't able to do that this week during my lunchtime if I am not on site, right? But otherwise, I am pretty much in a very office-like setting where I've set up an office and come to my office and in the office asset where I'm doing calls and meetings and problem solving from a set number of hours each day, and sometimes late in the evening after I put my little girls to bed.
I love that you're playing the piano every day. You know, I've asked a lot of people about their productivity routines or their daily routines, and I have not heard a lot of people say that. So I think that's awesome that you still play music. May I ask what kind of music you're typically playing? You're doing
Well,
classical or jazz?
it's classical.
Yeah.
It's classical. The piece I'm working on right now is a Bach piece right now. It's from the Well Tempered Clavier, Prelude 9. So it's going to take me a while because 30 minutes is not much time to practice, but it's something that I love doing, something that I was not able to do when I was a consultant in another setting or even working in an office. So I'm really glad that I'm able to do that.
What's it mean to you? How is your day different on days when you have that piano practice and the days when you don't?
Oh, I am nicer. Can I say that? It is the time where I am able to, because I'm focusing so much on learning the piece or practicing the piece, that I'm actively trying and sometimes succeed thinking of anything else. So I feel like I have had a great big like sloppy burger with all the fries and the ketchup, and I have had my treat. And then I can calm down and say like, okay, you got the treat first. Now let's do this. And I mean, a lot of the work that I do, I consider a treat also. But I love just being able to even psychologically say that you have taken this time out and I've done me. And now I'm coming to give part of me to someone else.
And what about the painting? Tell me a little bit about that. Is there any place online where we can see some of your work? And tell me a little bit about your painting.
I started the painting by looking at YouTube videos. And actually, that's still what I'm able to do. I send pictures of the paintings to my friend, and they're like, oh my God, this is so amazing. We didn't know you were so talented. I'm like, I am not. I can follow instructions. So I follow instructional videos on YouTube, and I do mainly landscapes because I just love the openness and the feeling of being outside. And if I can't do that, I'm going to paint about it. It's very similar to the piano playing where I'm so intent on doing that thing that everything else is sort of stewing and on the back burner for a little bit, and then I come out and able to focus more.
Bibi, where can folks who want to learn more about what you're doing and perhaps get in contact with you, what's the best place for them to go?
My website would be the best place. So I formed an LLC when I went independent. It's called soundhealthadvisory.com. That's a website. And it's a play on the sound advice I hope to give, the sound health I hope to have. And it's a place where you can find information, contact information for me. And of course, there's also LinkedIn, where Afua Branoah Banful is the name to search.
Great. We'll include links to those in the show notes. Any books that have really shaped you?
The book that I have read most recently and top of my mind has been David Field's book, the one about the irresistible consultant. for obvious reasons. A book that shaped me so much when I first was thinking about what I'd do in engineering and stuff was Stephen Hawking's A Brief History of Time. I think that was the title. I read it when I was 13 or so. And whenever I think about any book that has actually had the biggest impact on me, that's the one. I, in the only time in my life, skipped class because I was holed up in the library reading that book as a 13-year-old. And I came out with my mind blown. And yeah, so that's it.
That is awesome. Perhaps the first and only ever person to skip class for reading Stephen Hawking, but it was a page turner. I remember reading it in high school.
Yeah,
that's a great story.
Awesome. It's awesome.
Well, Bibi, thank you so much for joining. I really enjoyed our discussion. It was cool learning about telehealth and all the stuff that you have working on. So thank you so much.
Likewise. It was my pleasure to be here.
Thanks for listening to this episode of Unleashed, the show that explores how to thrive as an independent professional. Unleashed is sponsored by Umbrex, the world's first global community of top-tier independent management consultants. The mission of Umbrex is to create opportunities for independent management consultants to meet, share lessons learned, and collaborate. I'd love to get your feedback and hear any questions that you'd like to see us answer on this show. You can email me at unleashed@umbrex.com. That's UMBREX.com. If you found anything on the show helpful, it would be a real gift if you would let a friend know about the show and take a minute to leave a review on iTunes, Google Play, or Stitcher. And if you subscribe, our show will get delivered to your device every Monday. Our audio engineer is Dave Nelson. Our theme song was composed by Gary Negbauer, and I'm your host, Will Bachman. Thanks for listening.